approach according to are you guys listening? Let's start this topic. So today we are going to discuss about the basic principles to apply in trauma assessment and management, and how to apply the ATLS protocols in patients of trauma, and how to identify the life-threatening conditions and their early assessment and management. So we will optimize the management strategy according to MRCS standards, and how to solve the MCQs that will come from the trauma. We'll move on to the next slide. So what is trauma? Trauma is any physical injury or wound caused by the external force. Nowadays, trauma is the leading cause of deaths in individuals who are under 45 years of age. So it is the leading cause of death in young adults. Early and systemic assessment and management of the patients reduces morbidity and mortality. You have learned about the golden hour. If you treat the patient early in golden hour, it can reduces the morbidity and mortality. So today we are going to discuss about how to initially assess the patient and how to manage it properly. So the cornerstone of today's topic is how to apply the ATLS protocols in trauma management and assessment. So following trauma, there is a tri-radical death distribution. 3 types of distribution: a death immediately following injury, in early hours following injury, and in the days following injury. Immediately following injury typically occur as a result of brain injuries or high spinal injuries or injury to major vessels. In these patients, salvage rate is very low. Mostly these patients die at the scene of injury and don't make it to the hospital. In early hours following injury, in this death group are the patients due to phenomena such as splenic injuries, hemothorax, pneumothorax. But in such patients, if we assess the patient early and treat them within time, then we can save these patients' lives. So this is a very important thing. In the days following injury, you have managed the patient in the early hours, but late in the days after trauma, they can die due to air embolism, multi-organ failure, or sepsis. So there are 3 patterns of death distribution after trauma. Let's move to the next slide. How to assess and how to manage the trauma patient. You have learned about the ATLS protocols. ATLS protocols include primary survey and secondary survey. In primary survey, we do ABCD approach, and in secondary survey, we go through the thorough examination from head to toe of the patient. So what is ABCDE approach? In primary survey, we apply ABCDE approach for the patients who came with trauma. But if a patient come with bleeding, profuse bleedings, then we will change this approach from ABCDE to CABCDE. What is A? In A, we manage airway. In B, we manage breathing. And in C, we manage circulation. D, we manage any deformities. And E, we manage exposure and environment. So if a patient present with tension pneumothorax, avoid giving vigorous ventilation attempts in such patients, because if you attempt vigorous ventilation attempts in patients with pneumothorax, it will aggravate the pneumothorax without chest intubation. So always pass first chest intubation, and then go for ventilation. If a patient came with profuse external bleeding, then it will be managed as CABCDA. First, you will apply pressure at the bleeding and do pressure dressing, then go towards the airway. Because if he is bleeding profusely, he will die of hypotension and shock. If a patient present with external hemorrhage and profuse bleeding, do not panic and do not apply tourniquets. Blind application of tourniquets and blind application of clamps may cause damage to surrounding structures, nerves, and vessels. So first, do not panic and apply pressure. Pressure dressing is the preferred method of hemorrhage control. If you are passing urinary catheters or nasogastric tubes to the patient, that may be needed, but Before passing that, first rule out the base of skull fractures and urethral injuries, because this will aggravate these injuries. Now, if a patient presents with head and neck trauma, you must have to assume that this patient have a cervical spine injury until proven otherwise. Always stabilize the cervical spine. If a patient came with trauma, always stabilize the cervical spine with airway. So it is in A, it is airway stabilization with cervical spine stabilization. Let's move to the next slide. What is the framework of primary survey? In this survey, we immediately assess life-threatening conditions which can be managed immediately, and patient can be treated. So, but resuscitation should also be done simultaneously with the primary survey to stabilize the patient and to keep the circulation. In secondary survey, we do, as I told you earlier, thorough head-to-toe evaluation after stabilization of the patient. First we do optimization, and then we do thorough examination of the patient. And then we will go towards the definitive care. In definitive care, what includes definitive care? First, you have saved the patient life. Then we go towards the ongoing management. That includes surgery for different conditions or intensive care of the patients. Now, I will talk about shortly, what is airway. A for airway with cervical spine protection. First, how we assess the airway. Always check for the airway patency and look for the signs of obstruction. Suppose if a patient is talking, that means his airway is patent. And you can also look for the other signs such as snoring. Patient is snoring, patient has wheezing, or patient has stridor. It means there is some obstruction in the upper airway. So we will first assess it, and we'll go towards the management. Management includes temporary techniques and definitive airway techniques. How to stabilize the airway. In temporary techniques, we just do the jaw thrust, chin lift, and suction management of the patient. In definitive airway, we will do tracheostomy, cricothyroidotomy, and endotracheal intubation. So these are the definitive airway. Then also stabilize the cervical spine along with the airway. It is essential in all trauma patients. Now let's move to the breathing. In breathing and ventilation, start with the protocol of inspection, palpation, percussion, and auscultation. In inspection, look at the chest wall movements. Either both chest wall are moving equally or not. If half of the hemithorax is not moving, it means there is some underlying trauma to the lungs. That may include pneumothorax, hemothorax, or tension pneumothorax, hemopneumothorax. So always look at the chest movements first, and look at and count the breathing rate. Either patient is in tachypnea or not. And then go for the palpation. Palpate for any crepitus or surgical emphysema or any rib fracture. You can feel it. And also measure the chest wall movement, chest wall expansion. Then go for the percussion note. In normal patient, the percussion note is normal, resonant. But in tension pneumothorax or pneumothorax, percussion note will be hyperresonant. And in hemothorax, percussion note will be dull. So this is the main point, how we differentiate between the pneumothorax and hemothorax. Then go to for the auscultation. On auscultation, if there is equal air entry on both sides of the lung, then there is no underlying injury. If on auscultation, the breath sounds are absent on one side or other side of the chest, it means there is underlying pathology. Either it may be pneumothorax or it may be hemothorax. And if on auscultation, you don't find any changes in resonant note, you just find muffled heart sounds, that it means there is a cardiac tamponade. So these are the most important points to differentiate. How to differentiate between pneumothorax and cardiac tamponade. In pneumothorax, on percussion note will be hyperresonant, but in cardiac tamponade, percussion note will be normal, but there are muffled heart sounds. In tension pneumothorax, heart sounds will be normal. So this is the main differentiating point. Now, there are 6 potentially immediately life-threatening conditions and 6 potentially lethal conditions. What are immediately life-threatening conditions? These are tension pneumothorax, open pneumothorax, hemothorax, airway obstruction, and flail chest and diaphragmatic injuries. These can be managed immediately and patient can be saved. And there are 6 potential life-threatening injuries that include pulmonary contusion, cardiac contusion, aortic disruption, tracheobronchial injuries, or esophageal injuries. In these patients, patients mostly don't make it to the hospital and die at the scene of injury. So we will focus on the immediately life-threatening conditions. These can be managed. And patient can be treated. So always start with assessment and rule out the life-threatening injuries and go towards the management. So in tension pneumothorax, patient has hypotension, engorged neck veins, and absent breath sounds on the affected side. Trachea may be shifted to the opposite side. On auscultation, there will be absent breath sounds, and percussion note will be hyperresonant. So, what is the management of tension pneumothorax? Always start with needle decompression in the second intercostal space and the mid-clavicular line, and then go for the definitive management. What is definitive management of tension pneumothorax? Pass chest tube in the fourth or fifth intercostal space in mid-axillary line. This is a definitive management of tension pneumothorax. Then came for open pneumothorax or sucking chest wound. In open pneumothorax, first apply bandage, three-way bandage, in which we apply tapes on three sides and leave the one side. So tension after applying this three-way dressing, we will pass chest tube. When we pass chest tube, we can close this wound. So this patient will also be managed. And in hemothorax, pass the chest tube in the fifth intercostal space in mid-axillary line. And in hemothorax, we pass wide bore chest tubes. So what are the indications for thoracotomy in hemothorax? Suppose you have passed a chest tube and there is a drainage of 1500 ml of blood immediately. Then this is an indication for emergency thoracotomy. Or you have passed a chest tube, but there is 200 ml of blood per hour for consecutive 8 hours. This is also an indication for thoracotomy. Now move towards the cardiac tamponade. In cardiac tamponade, in cardiac tamponade, there will be backstride. In backstride, what is backstride? In backstrides, there will be engorged veins, venous hypotension, engorged veins, and muffled heart sound. Muffled heart sound is the main point we differentiate from tension pneumothorax. What is the management of cardiac tamponade? And we also do ECG monitoring in cardiac tamponade patients. In such patients, ECG changes may present or arrhythmias may be present. So in cardiac tamponade, what is the management? In this, we do needle blood aspiration in the left ninth intercostal space. This is the most important point. We do needle decompression from the left ninth intercostal space. Even if 100 ml of blood is present in the pericardial space, it can cause cardiac arrhythmias and cause death. So let's move to the next slide. Circulation with hemorrhage control. How to assess the circulation status of the patient? There are the vital signs we can check the pulse of the patient. If patient is in shock or hypotension, pulse will be feeble or there may be absent pulse. Then look at the blood pressure. Patient may have hypotension or maybe blood pressure is not recordable. Then look for the capillary refill sign. It will be more than 2 seconds. And you can also look for the urinary output and any signs of external bleeding. There are different types of shocks, and you can manage according to that shock. Hypovolemic shock, which is the most common shock in hemorrhagic trauma patients, cardiogenic shock, obstructive shock, distributive shock, neurogenic shock, or spinal shock. Now, if patient is bleeding externally, what should we do? First of all, apply the pressure at the bleeding site and do pressure dressing, and then pass 2 wide bore IV lines and start giving patient fluids and blood transfusions. You can give 3 liters of ringer lactate or crystalloids up to 3 liters, not more than 3 liters, as it will cause coagulopathy, dilutional coagulopathy. And in trauma patient, always replace with blood. What is lost? Replace with blood. So we manage the patient with fluid, not more than 3 liters, and then after that we will start doing blood transfusion. What is D for disability or neurological status of the patient? There are different assessment tools for the assessment. Most commonly, we use Glasgow Coma Scale, which is GCS. Everyone should know about the GCS, and we also look for the pupillary light reflexes. What is GCS? GCS has 3 components: best eye response, best verbal response, and best motor response. In best eye response, there are 4 points. Best verbal response, there are 5 points, and in best motor response, there are 6 points. In eye, if patient responds to your command, spontaneous eye opening, then it is 4. If he opens eye on your command, then 3. If he opens eye on painful stimulus, then 2. If he doesn't open eye, then 1. In verbal, if he is talking normally, this is with value oriented in time and space, it is 5. If patient is disoriented, but speaking but disoriented, 4. If patient is speaking words, but they are incomprehensive. So 3, incomprehensive sounds. 2, not speaking. 1. Same for motor. If patient is following your command. 6, if painful stimulus localizes painful stimulus. 5, if withdraw on pain, then 4, abnormal flexion. 3, abnormal extension. 2, and if not responding. 1. So minimum GCS score is 3. In a dead patient, GCS score is 3, or in a patient who is in vegetative state, GCS is 3. Now look for the pupillary light responses. It will tell you about the underlying neurological status of the patient. You can also assess either there is an underlying hematoma or not. Now, early detection of the neurological deficits can guide towards the further management of the patient. Now let's move to the next slide. Exposure and environment control. When you have ruled out all the airway obstruction, breathing and circulation, and manage those injuries, then fully undress the patient to assess for the hidden injuries, such as to look for the imprint signs to rule out the underlying injuries, and then completely undress the patient and look completely thoroughly from head to toe. Environmental control. Mostly the patient of trauma came with hypothermia, and we are also giving fluids. It will cause further hypothermia in the patient. So using warm blankets, fluid bombers, and ambient heat can prevent the hypothermia, as hypothermia can also cause dilutional coagulopathy. So this is the basics about the ABCDE management. Now, how to do transfusions in major trauma. Mostly patients come in trauma are in hypotensive hemorrhagic shock. So always start with giving fluid challenge. Give 500 ml of fluid stat, and then replace, as I told you, always replace blood with blood. So blood is the most important transfusion in major trauma. So uncontrolled hemorrhage accounts for up to 39% of all trauma-related deaths. In the UK, approximately 2% of all trauma-related patients need massive transfusion. Now, what is massive transfusion? Massive transfusion is the replacement of a patient's total blood volume in less than 24 hours, or as the acute administration of more than half of the patient's estimated blood volume per hour. So in hemorrhagic patients following trauma, there is evidence to support the initial administration of tranexamic acid has markedly reduced the mortality rate. So tranexamic acid is important in trauma patient in reducing mortality. What is homeostatic resuscitation? Always transfuse blood products in a ratio 1:1:1. Transfuse 1 packed cells, 1 FFPs, and 1 platelets. Always administer in this ratio. This is hemostatic resuscitation. Now, what is the endpoint of resuscitation? When to stop our resuscitation, and when to rule out that our patient is stable. When HP of the patient is 8 to 10 gram per deciliter, platelets greater than 100, when INR is less than 1.5, and fibrinogen level are greater than 1 gram per liter, when calcium is greater than 1 millimole, and pH is normal, 7.35 to 7.45, base deficit less than -2, and patient is not in hypothermia. Patient's body temperature must be greater than 36 Celsius. So at this point, we can stop our resuscitation and go towards a definitive management. What is thoracic trauma? Let's talk about this, as mostly questions came from thoracic trauma and abdominal trauma. What are the key points? In less than 10% of chest traumas, 15 to 20% of penetrating chest traumas require operative intervention. As I told you earlier, the indications for thoracotomy. The physiological consequences of thoracic trauma are hypoxia, because the patient is not ventilating properly, hypoxia because of decreased oxygen supply, hypercapnia because patient is not breathing properly, so carbon dioxide is retaining the body, that will cause hypercapnia, and acidosis. Now patient may have metabolic acidosis or respiratory acidosis. In contusions, hemothorax and alveolar collapse or changes in intrathoracic pressure relationships, such as in tension pneumothorax or open pneumothorax, patient can have metabolic acidosis. Why metabolic acidosis is happening in such conditions? Because of anaerobic respiration, patient lactic acid is producing, that is causing metabolic acidosis. Now, as patient is also having hypercapnia. As I told you, hypercapnia, carbon dioxide acts as an acid in the body. So if body is retaining carbon dioxide, hypercapnia can cause respiratory acidosis. So most often follows inadequate ventilation. This is caused by changes in intrathoracic pressure resulting from the depressed level of consciousness. If patient is in semi-conscious state and patient is hypoventilating, that may cause hypercapnia and that may cause respiratory acidosis because of carbon dioxide retention. What are the types of thoracic trauma? As I told you earlier about the tension pneumothorax, open pneumothorax, pneumothorax. Now let's talk about the pathophysiology. In tension pneumothorax, it occurs due to laceration in the lung parenchyma, which leads to the formation of a flap valve mechanism. Means air is coming out of the lung into the pleural space but can't go back. So it is trapping in the pleural space and increasing pressure in the pleural space. The most common cause of tension pneumothorax is mechanical ventilation in patients with pleural injury. Suppose a patient is already have pneumothorax and we are giving mechanical ventilation, which is increasing pressure in the pleural space. So in spite of improving patient ventilation, it is deteriorating the patient condition. So its symptom can overlap with the cardiac tamponade, but hyper resonant percussion node is present in tension pneumothorax, not in cardiac tamponade, and muffled heart sound present in cardiac tamponade, not in tension pneumothorax. What is pleural chest or flail chest? In flail chest, chest wall disconnects from the thoracic cage. What is the definition of flail chest? How we can say that it is a flail chest? If on X-ray there are at least two ribs of 2 or 3 fractures at more than at 2 or more than fracture of 2 or more than 2 ribs, consecutive ribs, or at least 2 points, that leads to the paradoxical chest wall movements. It is a flail chest. Fracture of 2 or more than 2 consecutive ribs at least 2 or more locations, that lead to paradoxical chest wall movements. It is associated with pulmonary contusion. It is associated with pulmonary contusions that may cause hypoxia, abnormal chest wall movements. In such patient, we may need mechanical ventilation and chest intubation. Keep these patients pain-free, as it will improve the patient condition. Avoid overhydration and fluid overload in such patients. Now let's move to the next slide. It is pneumothorax, open pneumothorax or pneumothorax. Most common cause of pneumothorax, simple pneumothorax, is lung laceration with air leak. In this, flap valve mechanism is not developed yet. Most traumatic pneumothoraces should have a chest drain. So chest drain should be passed, which is a definitive management of pneumothorax. Patient with traumatic pneumothorax should never be mechanically ventilated, as it will aggravate the patient's condition before chest intubation. If we have already done the chest intubation and patients need mechanical support, we can do it after chest intubation, but not before chest intubation. What is hemothorax? Hemothorax can occur due to laceration of lung parenchyma, laceration of intercostal vessels, or internal memory artery. So hemothorax large enough to appear on the X-ray must be treated with urgent wide bore chest intubation. Surgical exploration indications are if you have passed chest tube and 1500 ml of blood drained immediately. If you have passed chest tube and there is 200 ml of blood per hour for consecutive 8 hours, then go for thoracotomy and surgical exploration. What is cardiac tamponade? If 100 ml, if at least it may occur with as little as 100 ml of blood in the pericardium. So what is Beck's triad? Beck's triad is a triad that contains elevated venous pressure, decreased arterial pressure, and muffled heart sounds. So how we differentiate it from tension pneumothorax, I told you earlier. In cardiac tamponade, neck veins will be engorged and pulsus paradoxus will be present. So its management is do needle aspiration in the left ninth intercostal space. What is pulmonary contusion? Pulmonary contusion includes in potentially life-threatening conditions. This is the most common potentially lethal chest injury. In these patients, ABGs must be done at regular intervals and pulse ox should be applied. Early intubation within 4 hours if patient within 4 hours if patient presents significant hypoxia. What is blunt cardiac injury or cardiac contusions? Usually, it occurs secondary to chest wall injury on the left side or blunt trauma to the left side of the chest. In these patients, ECG may show features of myocardial infarctions or arrhythmias. Patient may show hypotension, arrhythmias, cardiac wall motion abnormalities. So, in such patients, echocardiography must be done, and continuous monitoring should be done. What is aortic disruption? Aortic disruption is also a potentially lethal chest injury. These aortic disruptions occur in deceleration injuries. In this, how we diagnose it? On chest X-ray, there will be widened mediastinum and contained hematoma. Mostly, these patients die at the scene of injury and do not make it to the hospital because of massive bleeding. Diaphragm disruption, mostly due to motor vehicle accidents and blunt traumas to the abdomen and chest, causing large radial tears in the diaphragm. Laceration injuries result in small tears. It is more common on the left side because on right side, liver is present. Liver prevents such injuries on the right side. Now, how to assess that there is a diaphragmatic disruption? If you pass gastric tube in the patient, this will go and coil in the thorax or in the intrathoracic stomach if stomach herniation has occurred. So NG will not pass below the diaphragm on X-ray. What is mediastinal traversing wounds? In such wounds, entrance wound is one hemothorax and exit wound is in the opposite hemothorax. On chest X-ray, findings will be mediastinal hematoma, widened mediastinum, or pleural gap, suggesting of great vessel injury. In such patients, mortality is 20%. Let's talk about the thoracic aortic rupture. What is the mechanism of injury? Decelerating forces, RTA, fall from a great height can lead to the aortic rupture. Mostly, patients die at the scene of injury due to hypovolemia and extensive hemorrhage. Survivors may have patient who can make it to the hospitals and who can survive may have an incomplete laceration at the ligamentum arteriosum of the aorta. What are the clinical features in such patients? Contained hematoma and persistent hypotension. You are giving patient fluids and blood, but patient is not responding. So this is persistent hypotension and contained hematoma. You can detect it by taking history of the patient and chest X-ray changes. What will you find on the chest X-ray? On chest X-ray, there will be widened mediastinum, trachea and esophagus shifted towards the right, depression of the left main stem of bronchus, widened paratracheal stripe or paraspinal interfaces. Space between the aorta and pulmonary artery will be obliterated or fractures. A left side of hemothorax may be present. I'll show you the X-rays of thoracic aortic rupture and pneumothorax at the end of the session. How to diagnose such patients? By doing angiography, usually CT and aortogram. Treatment is repair of the aorta or replacement. Ideally, they should undergo endovascular repair. It reduce the morbidity and mortality as compared to open surgical repair. Now, let's talk about the abdominal trauma. Abdominal trauma mostly occur in deceleration injuries. In blunt trauma requiring laparotomy, if a patient present with blunt trauma and we are going to explore the patient, the spleen is the most commonly injured, 40%. In stab wound injuries, most commonly injured structure is liver, 40% of the patient. In gunshot wounds, most common structure injured is small bowel, as in 50% of the patients. Patient with stab wounds, but patients who present with stab wounds, but there are no peritoneal signs. It means that peritoneal cavity has not breached, and it can occur in 25% of the patients. So in blunt trauma, spleen injuries are common. In stab wounds, liver injuries are common, and in gunshot wounds, small bowel injuries are common. But in gunshot wounds, we'll follow the trajectory of the bullet. A blood at, if a patient presents and you are passing the patient Foley's and there is blood at the meatus, that can suggest you a urethral injury. So avoid passing Foley's in such patients and first rule out the urethral injury. If on PR there is a high riding prostate, that may also concludes a urethral injury. Medical testing for pelvic stability should only be performed once, and it may cause hemorrhage or bleeding if you do it multiple times. Let's move to the next slide. Now, how to investigate the abdominal trauma? There are three basic tests to do investigation in some patients. Diagnostic peritoneal lavage, abdominal CT scans, and ultrasound, such as FAST. Every test has different indications and different pros and cons. So first talk about the diagnostic peritoneal lavage. Its indication, it can document intraperitoneal bleeding if patient is persistently hypotensive. Its advantage is early diagnosis and sensitivity about 96%. And in 96% of the patient, it is accurate. But its disadvantage is that it is invasive process and it may miss the retroperitoneal and diaphragmatic injuries, as you can't see there. Abdominal CT scan, if a patient presents with any suspected organ injury, so go for, and patient is normotensive, there is no hypotension, document. So use abdominal CT scan to document any organ injury. Its advantage is that it's more specific for localizing injury. 92 to 96% are accurate. But its disadvantage is that patient may need contrast. Location of the scanner may be away from the facilities and time taken for reporting of the CT scan. Now let's talk about the FAST. Focus assessment sonography of trauma patients. Indication is it will document about the intraperitoneal fluid if patient is hypotensive, but it won't tell you either this fluid is blood or just peritoneal fluid. But if a patient is hypotensive, it will tell you about it. Its advantage is early diagnosis. It is non-invasive and repeatable. But in 86 to 95% of the patient, it is accurate. But its disadvantage is that it is operator dependent and it may miss the retroperitoneal and diaphragmatic injuries. Let's move to the next slide. Now let's talk about head injuries shortly. Patients who suffer head injuries should be managed according to ATLS protocols. But you shouldn't miss the extracranial injuries. You should also manage the cranial injuries alongside with the head traumas. As inadequate cardiac output will compromise the CNS perfusion, inspired the nature of the cranial injury. What are the types of traumatic brain injury? Most common scenarios came from extradural, subdural, and subarachnoid hemorrhage. So let's talk about these shortly. What is extradural hemorrhage? In this, bleeding into the space between the dura mater and the skull that compresses the brain. Often results from acceleration, deceleration trauma or a blow to the side of the head that leads to the rupture of middle meningeal artery. Most important point is rupture of middle meningeal artery, and it is more common in the temporal region. What are the features? In these patients may present with raised intracranial pressure, reduced GCS, and some patient may exhibit a lucid interval. What is a lucid interval? Lucid interval is a period of consciousness between two episodes of unconsciousness. An episode of consciousness between two episodes of unconsciousness. This is a lucid interval, and this is the most important point in ruling out extradural hematoma. What is subdural hematoma? Subdural hematoma is the bleeding in the outermost meningeal layer. Most commonly occurs around the frontoparietal lobes. It may be either acute or chronic, and the symptoms progression is slow in subdural hematoma as compared to extradural hematoma. And patient may be stable if it is small and can be discharged. These factors include old age and alcoholism. Suppose if a patient present with subdural hematoma in old age or in alcoholic patient, he may get stabilized in a few days and discharged. But after a few days, he may came again with decreased GCS due to chronic subdural hematoma. So it has slower onset of symptoms than extradural, but it is less lethal than extradural hematoma. What is subarachnoid hemorrhage? Subarachnoid hemorrhage can be spontaneous or can be traumatic. Spontaneously occur in the context of a ruptured cerebral aneurysm, but traumatic injuries can occur. Let's move to the next slide. What is the pathophysiology of brain injury? Primary brain injuries or secondary brain injuries? Primary brain injuries may be focal or diffuse. In focal, there is contusion or hematoma. In diffuse, there is, for example, diffuse axonal injury. Diffuse axonal injury occur as a result of mechanical shearing following deceleration that cause disruption and tearing of axons. Intracranial hematomas can be extradural, subdural, and intracerebral, while concussions are focal. So this may occur adjacent to the impact of injury or opposite side, contralateral to the impact of injury. If these are adjacent to the side of injury, these are coup, and if they are contralateral to the side of impact, they are counter coup. So, how secondary brain injury occur? Secondary brain injury occurs when cerebral edema, ischemia, infection, tonsillar, or tentorial herniation exacerbates the original injury. So, the normal cerebrospinal fluid regulatory processes are disrupted following trauma, rendering the brain more susceptible to blood flow changes and leading to hypoxia. What is Cushing's reflex? Cushing's reflex is a triad that includes hypertension, bradycardia, and labored breathing. Often occurs late, and it is usually a pre-terminal event. So it is a most important sign in head trauma patients. How to manage these patients? These patients will be managed accordingly, according to the type of hematoma. But the basic conservative management includes, if a patient present with a rising intracerebral pressures, then give patient IV mannitol and furosemide until the patient surgery is planned. So it will reduce the intracranial pressure. Diffuse cerebral edema may require decompressive craniotomy, and but we can also do exploratory burr holes, but these are now obsolete as the CT scan has more CT scans are available. So decompressive craniotomies can be done, and in extradural hematoma and subdural hematoma managed according to the symptoms of the patient. How to manage depressed skull fractures? If depressed skull fractures are open, they will require open surgical reduction and debridement. If closed injuries are present, they can be managed non-surgically, and they can be managed conservatively if the symptoms are minimal. Intracerebral monitoring is appropriate when in such patients who have a GCS of 3 to 8 with normal CT scan. But ICP monitoring is mandatory in patients whose GCS is 3 to 8 with abnormal CT scan. Most likely due to the syndrome of hyponatremia is most likely due to the syndrome of inappropriate secretion, cerebral salt wasting syndrome. What is the cerebral perfusion pressure? Minimal cerebral perfusion pressure in young adults is 70 mm of Hg, but in children, minimal cerebral perfusion pressure ranges from 40 to 70 mm of Hg. Now let's talk about the, let's move to the next slide. And let's talk about the pupillary light reflex and how to assess according to the pupils. If pupil size is dilated unilaterally and light response is sluggish or fixed, we can interpret that it is a third nerve compression secondary to tentorial herniation. If pupil size is bilaterally dilated and light reflex is sluggish or fixed, it may be due to poor CNS perfusion, bilateral third nerve palsy. If pupil size is unilaterally dilated or equal, then this is a and the pupillary light reflex is cross-reactive markers, which we call marcus conpupil. Then we can suspect optic nerve injury. If both pupils are bilaterally constricted, this will be difficult to assess as both are bilaterally constricted and nothing to compare. Then it may be due to opiate poisoning, cerebral pontine lesions, and metabolic encephalopathy. If unilaterally constricted and pupil light reflex is normal, then sympathetic pathway disruption can occur. Let's talk about burns, as most patients came with burns. There are basic four types of burns: superficial burns, superficial partial thickness burn, deep partial thickness burn, and full thickness burns. In superficial, how to differentiate between these burns? In superficial burns, skin layer affected is epidermis. Skin appear red and moist. Blanching is present, and this will be managed conservatively and leave no scar. In superficial partial thickness burn, epidermis and part of papillary dermis is affected. In this burn, skin appear pale and dry. Blanching is present, and management is normally these patient heals itself with no intervention needed and leaves no scar. Deep partial thickness burn that includes epidermis, whole papillary dermis, epidermis, and whole papillary dermis. In these patients, skin appear mottled and red in color. Blanching is not present. These patients need surgical intervention. What is full thickness burn? In full thickness burn, skin layers affected are whole skin layer and underlying subcutaneous tissue affected. Skin will be dry and leathery, and the blanching not present. These patients must be managed in burn centers. How to assess the burn, depth of burn, what type of burn it is? Check for the bleeding or needle prick. Check for the sensations, as sensations are lost in full thickness burn. Check for the appearance of skin and blanching to pressure. Blanching is present in superficial and superficial partial thickness burn, but not present in deep and full thickness burn. How to assess the percentage? There are different charts available to assess the percentage of burn. Most common are Lund-Browder chart, most accurate, mostly, and even in children. And there is also a Wallace rule of 9. We mostly use Wallace rule of 9, and you can also assess through the palmar surface. A surface of a palm is equal to 0.8% burn. So you can calculate if there are patchy burns. You can use your palm and calculate it accordingly. Now, in home patients, we should start resuscitation, and home we should transfer patient to the burn center. If in adults, body surface area of burn is greater than 15%, and if in children, body surface area of burn is greater than 10%, such patient needs urgent fluid resuscitation and transfer to burn center. And also, if patient has burns on the face, hands, and in genitalia, then the patient should also be managed in the burn center. A deep partial thickness burn or full thickness burn, electrical burns, and chemical burns also be managed in burn centers. Okay, what is ischiotomies? In home patients, in home, ischiotomies should be done. That is the indication. If there is a circumferential full thickness burn to the chest, abdominal limbs, torso limbs, you must do ischiotomies to prevent the ventilation of the patient. Careful division of the encasing band of the burn tissue potentially improve the ventilation if it involves the chest, and relieve the compartment syndrome in limbs, as it may compress the blood vessels and cause necrosis. Let's move to the next slide. How to manage fluid, how to do resuscitation in burn patients. As I told you earlier, the indication greater than 15% of total body area burn in adults and greater than 10% in children. What is the aim of resuscitation? Aim of resuscitation is to prevent the burn deepening. Mostly fluid in burn patient is lost in first 24 hours due to endothelial injuries. So first 8 to 12 hour fluid shifts from the intravascular compartment to interstitial fluid compartment that leads to edema. So therefore, circulatory blood volume is compromised. So we should start giving fluid. We should start resuscitation as soon as we receive the patient. So it causes more fluid in the interstitial compartment, especially colloid. So we should avoid colloids in the first 8 to 24 hours. As it will pass from the intervascular compartment to the interstitial compartment, increasing the edema, making make it worsen. So avoid colloids in the first 24 hours and give crystalloids in the first 24 hours. What is the formula to calculate the fluid? In patients of burn, we calculate by Parkland formula, which is 4 ml into total burn surface area, percentage of total burn surface area into body weight. So crystalloids only, Hartmann solution such as and Ringer lactate solution should be given. 50% of this fluid we calculated should be given in the first 8 hours, and the remaining 50% should be given in the next 16 hours. And if if patient has already received fluid before coming to the hospital, we should subtract this fluid from our calculation. How to know that we should stop resuscitation now? When the urine output of the patient is zero point 0.5 to 1 ml per kg per hour, if patient's urine output is 0.5 ml to 1 ml per kg per hour, then we should stop resuscitation. We have resuscitated the patient enough and optimized the patient. So what are the most important points to note? The most important points to note are: starting point of resuscitation is the time of injury. So always count from the time of injury. Always count 24 hours from the time of injury and detect the fluids already given. After 24 hours, you can give colloids infusion after 24 hours, and you can begin it at a rate of 0.5 ml into total body burn surface area into body weight. Maintenance fluid given, maintenance fluid may crystalloid should be given, usually dextrosaline, and continued at a rate of 1.5 ml into body burn surface area and body weight. Colloids used after 24 hours include albumin and FFPs. Antioxidants such as vitamin C can be given, as the oxidants may contribute to the inflammatory cascades. So if we give antioxidants, it can reduce the inflammatory cascades and reduce the inflammation and edema. High tension electrical burns and inhalational injuries require more fluids. In such patients, in electrical burns and inhalational burns, we do not calculate the fluid. We just give the fluid and see the urine output. When the adequate urine output, 1 to 2 ml per kg per hour came, then we stop resuscitation. And we do monitoring by pack cell volume, plasma sodium, base excess, and lactates. We do ABGs of the patients regularly. Let's move to the next slide. How to manage the head injury. Now, there are a few guidelines in which patient we should go for urgent CT scan, and in which patient we should urgently refer the patient to neurosurgery. What is the NICE guideline? All patients of head injury should be assessed within 15 minutes on arrival to emergency, and document all the three components of GCS. If a patient present with GCS 8 or less than 8, always consider stabilizing the airway and cervical spine. If patient is in pain, treat the patient with low dose IV opiates if it is safe in the patient. Full spine mobilization should be done until proven otherwise. So if the patient presented with GCS less than 15, neck pain and neck tenderness, paresthesia of limbs, or any focal neurological deficit, always suspect cervical spine injury. If you are suspecting a cervical spine injury, apply a head collar immediately and go for a 3-view cervical spine X-ray. What are the indications of CT scan in cervical spine injury? If a patient is intubated, if the patient GCS is less than 13, and the patient's X-ray is normal, but you are still suspicious regarding cervical spine injury, go for CT scan. Now, what are the indications for CT scan in head injury? Immediate CT scan, or when to contact the neurosurgeon. Immediate CT scan within 1 hour should be done in patients whose GCS on admission is less than 13. GCS is less than 15, 2 hours after admission. At the time of admission, GCS was 15 but dropped by 2 points after 2 hours. Suspected open or depressed skull fracture, suspected base of skull fracture, such as patient present with panda eyes, raccoon eyes, Battle sign, CSF rhinorrhea, CSF otorrhea, or focal neurological deficits, more than 1 or 2 episodes of vomiting, post-traumatic seizures, coagulopathy, retrograde or antegrade amnesia. In such patients, go for immediate CT scan within 1 hour. If a patient present with persistent GCS 8 or less than 8, unexplained confusion for more than 4 hours, reduced GCS after admission, or progressive neurological signs, incomplete recovery post seizures, or penetrating injury to the head or cerebrospinal leg, urgently refer the patient to neurosurgeon. And how to observe these patients? Such patients should be observed with half-hourly GCS monitoring. Let's move to the next slide. So this is an X-ray of tension pneumothorax. Look at this X-ray. On the right side, there is tension pneumothorax. You can see the lung border, medially collapsed lung border, pneumothorax present with absent lung markings. This is jet plaque area. Deep sulcus sign with depressed right diaphragm. Mediastinal shifted towards the opposite side. Subcutaneous emphysema. You can see the subcutaneous emphysema on the extreme left side. A black shadow outside the rib. This is tension pneumothorax. Mostly such pictures came in the questions, and you have to diagnose what is the scenario, and you have to diagnose to manage. What is this? This is pneumothorax. Look at the right side. There is a air fluid level. So this is pneumothorax. Let's move to the next slide. This is simple pneumothorax, blunted left costophrenic angle. On the left side, you can see on the right side, costophrenic angle is normal, but on the left side, it is blunted. So it is pneumothorax. This is cardiac tamponade. In this, heart shadow is enlarged. You can see the enlarged globular heart, and mediastinum is shifted towards the opposite side. And the left main stem bronchus is also replaced. What is local anesthesia toxicity? It is not related to trauma, but we'll discuss it shortly. Toxicity may result from either accidental intravascular injection or from the excessive dosage. So local anesthesia not only exert a stabilizing effect on peripheral nerves, but it will also act as an act on excitable membranes in the CNS and heart. So first, the sensory response in the CNS suppressed, then the motor one. So as a result, symptoms will typically be of those cerebral paresthesia, tinnitus, followed by falling GCS and eventually coma. How to manage the toxicity? Local anesthesia toxicity. First of all, stop injecting anesthetic agent immediately. Give patient high flow oxygen, 100% oxygen through face mask. Start cardiovascular monitoring, ECG and SpO2 monitoring. Administer intralipid 20%, which is an antidote to local anesthesia. Add 1.5 ml per kg over 1 minute as a bolus. Consider lipid emulsion infusions at 0.25 ml per kg per minute. If toxicity is due to prelocaine, then administer methylene blue. What is the safe dose? Let's move to the next slide. What is the dosage of local anesthesia? Lignocaine without adrenaline and with adrenaline. Lignocaine, you can give 3 mg per kg of lignocaine without adrenaline, and if you have added adrenaline, you can give 7 mg per kg maximum dose. Bupivacaine 2 mg per kg with or without adrenaline. Prelocaine 6 mg per kg is the maximum dose without adrenaline, and with adrenaline you can use 9 mg per kg maximum dose. And you should avoid using adrenaline and arteries, such as in arms, such as in hands and in your feet, as it may cause ischemia. What is Addisonian crisis? It may occur as a result of sepsis or surgery that can cause an acute exacerbation of chronic insufficiency, Addison's disease, or hypopituitarism. It may also occur in adrenal hemorrhage, such as in Waterhouse resistance syndrome, that can occur as a result of fulminant meningococcemia. Or if a patient is already taking steroids, so steroid withdrawal can also cause Addisonian crisis. So how to manage such patients? Give hydrocortisone 100 mg IM or IV stat. As patients are in hypovolemic shock, so give 1 ml of 1 liter of normal saline over 30 to 60 minutes immediately as a bolus, along with dextrose if patient is in hypoglycemia. And then continue hydrocortisone at 60 mg per hour until the patient is stable. Oral replacement may begin after 24 hours and may be reduced to maintenance dose over 3 to 4 hours. What is hypocalcemia? The clinical history combined with parathyroid hormone levels will reveal the cause of hypocalcemia in the majority of cases. So causes are a vitamin D deficiency, as in osteomalacia, acute pancreatitis, chronic renal failure, hypoparathyroidism, for example, after parathyroid surgery, accidental removal of parathyroid glands, or post-thyroid due to ischemia. Pseudo-hypoparathyroidism, target cells are insensitive to PTH, rhabdomyolysis, magnesium deficiency, as magnesium is necessary for receptors to PTS to act on its receptors. How to manage such patients? Acute management of severe hypoglycemia includes intravenous replacement. The preferred method is give 10 ml of 10% calcium gluconate over 10 minutes. Rule of 10. 10 ml of calcium, 10 ml of 10% calcium gluconate over 10 minutes. ECG monitoring should be done as it may cause arrhythmias in the heart. Further management, uh, ECG monitoring is recommended. And further, you can shift the patient on the oral depending on the underlying cause. Calcium and bicarbonate should not be given at the same route as it may interfere in each other's absorption. Now, how to manage the trauma in pregnant patient, how to assess the patients. Sonography and fast scanning are established in pregnancy as we should avoid ionizing radiation in pregnancy. So fast and ultrasonography should be done in such patients. And we should not go for CT scan until it is a life-saving emergency. However, the sensitivity of fast scan is reduced in pregnancy due to increased size of the uterus, especially with advanced gestational age. Sensitivity of fast is 60 to 80% across all trimesters, but 90% in the first trimester. CT scanning remains, but still CT scan remains the first line investigation in major trauma, where significant visceral injury is suspected. So in whole body trauma, I forgot to tell you, in whole body trauma, multi-organ trauma, you must go for whole body 3D CT scan. This is the gold standard. Okay, visceral injury suspected. Maximum permitted safe dose of radiation in pregnancy is 5 ms. So pelvic CT scan is below this level. So early exposure in pregnancy, early gestation exposure to radiation will increase the risk of developmental anomalies and fetal loss. If you do late exposure, such as in late trimester, it increases the risk of childhood cancers 2 times the normal. So CT scanning remains the most sensitive test for identifying complications such as placental abruption in this group. This is the most important point. If you have to rule out the placental abruption, you must go for CT scanning. This is the most sensitive test. Let's move to the next slide. Wound healing. Surgical wounds are either incisional or excisional wound, and there are 4 types of wounds. Clean wound, clean contaminated wound, contaminated or dirty. Although the stages of wound healing are similar to contribution, but there are 4 main types, 4 main stages: hemostasis, inflammation, remodeling, regeneration, and remodeling. In hemostasis occur in minutes to hours following injury, and this vasospasm in adventitial vessels occur immediately. Then platelet plug formation and generation of a fibrin-rich clot. Inflammation typically occurs in 1 to 5 days following wound. In this phase, neutrophils migrate into the wound. Function is impaired in diabetes, so wound healing is delayed in diabetes due to this stage, inflammatory stage. Growth factors such as basic fibroblast growth factors and muscular endothelial growth factors are released. Fibroblasts replicate within the adjacent matrix and migrate into the wound. Macrophages and fibroblast complex matrix regeneration and clot substitution occur. So in this phase, neutrophils migrate, growth factors such as fibroblasts and muscular endothelial growth factors are released, and fibroblasts replicate and migrate. Macrophages and fibroblast may form couple matrix regeneration and clot substitution. Let's move to the next slide. Regeneration. Regeneration typically occurs in 7 to 56 days. Platelet-derived growth factor and transformation growth factors stimulate fibroblasts and epithelial cells. Fibroblasts produce a collagen network, angiogenesis occur, and wound resembles a granulation tissue. So regeneration occurs in 7 to 56 days, and granulation tissue forms in regeneration phase. What is remodeling? In remodeling, this granulation tissue will remodel. It is from 6 weeks to 1 year, the longest phase of healing process, and it may last up to 1 year or longer than 1 year. During this phase, fibroblasts proliferate and differentiate into myofibroblasts that cause contraction of the wound, and these facilitate the wound contraction. Collagen fibers are remodeled, and microvessels regress and leaving a scar. So this is the end of wound healing. Any questions related to this topic? Okay. Now let's move to the next slide. Now we are conducting a course regarding MRCS Part 1 preparation. This course includes 3 month duration, and it is starting from June 1. It will include live sessions by expert mentors, premium study rooms, a small study schedule, sessions recording can be done, and we will take tests according topic wise tests and 2 workshops of recalls, past papers, and grand mock exams. At the end of the session, we will do mock exams to test. So you can contact the number given and the email given, and you can join this course. Thank you. And we are also offering 30% off on this course for the September session. Thank you so much.